Hello and greetings from UB. On behalf of the Office of Alumni Engagement in the UB School of Management, we are delighted you are able to join us for today's webinar presentation. My name is Christy Fields and I manage the Alumni Lifelong Learning Program here at UB. I am also joined by my wonderful colleague Joy Rona, who will assist in monitoring any questions. We are both so grateful you are able to join us today and hope you and your family are staying well. It is my honor to welcome today's featured presenter, UB alumnus Marty Boryszak. Marty is currently serving as interim president of Sisters of Charity Hospital in Buffalo, New York. He was promoted to senior vice president of acute services in August of 2019. And in March 2020, Marty helped lead the transformation of Sisters Hospital St. Joseph's campus into a dedicated COVID-19 treatment facility, the first of its kind in New York State and one of the first in the country. He is also leading Catholic Health's COVID-19 system-wide response efforts. Marty joined Catholic Health in 2009, first as a director of finance for Sisters Hospital, and then was named vice president of operations for Sisters Hospital St. Joseph's campus in 2012. He was promoted to chief operating officer, overseeing both campuses of Sisters Hospital in 2014, and in 2017, Marty was named president and CEO of Sisters Hospital. Marty also holds an MBA from St. Bonaventure University. He recently completed certification in managing healthcare delivery through the Harvard Business School. Marty serves on Canisius High School Board of Trustees as well as the Sisters Hospital Foundation Board. He was named by Business First as one of Western New York's 40 under 40 for 2016 for his professional success and community involvement. In today's webinar, you will learn more about Marty's lessons learned in emergency and crisis management, what our hospital systems got right and what they could improve on moving forward, as well as get answers to your many questions regarding healthcare in the age of COVID-19. We are going to leave a lot of time today for Q&A. If you have any questions during the presentation and Marty's conversation, you can submit them through GoToWebinar. You're going to see on your taskbar there's a question section, and you can chat those to us at any time. In addition, we'll be recording today's session and we'll send you all a copy within the next 24 hours. With that said, it's my pleasure to turn it over to today's featured presenter, UB alumnus Marty Boryszak.
Thank you very much, Christy. Good afternoon, everyone. And that was quite the introduction. I'm going to have you come speak at my house in front of my wife, Christy. Thank you. So just a little bit about myself and a little bit about, I think, the experience that we're certainly dealing with today. And I think the biggest question or concern is really dealing with uncertainty and what we can do to really create some level of certainty when you really don't know what's in front of you. Christy walked through my background a little bit, but the part that was left out is that I don't have a healthcare background. I spent the first 10, 11 years of my professional career at United Parcel Service. So really, my early part of my career was spent on logistics and operations, not so much in the healthcare field. My wife and I made a decision to come back to Buffalo because it's home, and certainly Catholic Health is near and dear to me. I was actually born at Sisters Hospital, and some of the roles that I've had throughout the years at Catholic Health and Sisters are special to me in the sense that my mother was actually a nurse for 40 years at Catholic Health. So as we get into some of the things that we were dealing with, I just wanted to really talk a little bit about kind of Catholic Health, who we are, what we do, and really not anything more than an introduction to really some of the challenges that we faced really beginning in March. And all of the things that you would normally hear or want to hear about a healthcare system are important. We are high reliable, high quality. We actually are nationally recognized by Leapfrog from a quality perspective. Have good quality results across the board, patient experience and outcomes. Our mission, our value, and you'll see in the presentation, is really focused around the patient. We are or have been our founders and foundresses were ministries of the church. And really a lot of our mission, vision, values are driven around really compassionate care and really putting the patient at the center of everything that we do. From an organizational perspective, Catholic Health has more than 10,000 employees. We have 4 hospitals, 5 campuses, and more than 60 locations on the practice management side. And that's everything from primary care to specialty care, vascular, cardiac, and everything in between. So we are really a full service system. We do manage the continuum of care. and we've been doing so for quite a long time in Western New York. So that brings us to, I think some of the things that we're here to really talk about today. And, we were kind of going along business as usual in the early part of January, busy with flu, or what we thought was flu. And healthcare as a whole really has a largely decentralized model, okay? We have acute care campuses that are regionalized. We have primary care that refers into those. We do our best to keep the patient at the middle. But when you have uncertainty that's kind of slammed down your throat, like COVID was, it really creates more questions than answers, especially around, what we didn't know at the time, which around COVID was just about everything. Our first PUI, patient under investigation, really hit our door in late February, like actually the last day of February this year. And from there, we knew that it had hit really this region, and it was only a matter of time as far as what we would have to be prepared for. So we started to really rack our brains, and what you see on the screen here is really just kind of some of the brainstorming that went on around, kind of a decentralized model, but what do we have? What can we do? What's our availability as far as PPE? How much staff do we have to take care of a surge? Where do we have capacity, building, equipment, everything in between, to really focus on, what we didn't know, which was how bad this could potentially get. And so, ultimately, in early March, we started to see all of our hospitals, all of our locations get inundated with really COVID-like symptoms. For those of you that weren't close to it, and those of you that were, will know, or maybe not, that testing was a real challenge really across our country. We did not have significant testing resources. We did not have testing methodology that really deemed rapid tests. The testing availability was few and far between. The county opened up its incident command, had the ability to test, a very small percentage. Both us and Kaleido were struggling really because we did not have a testing algorithm or a testing platform that could be readily deployed early on in the pandemic. So as COVID hit, we were trying to figure out what's the right thing for us to really take a look at and do. At the time, I was actually running all of the acute care facilities. We were doing some tabletop drills at one of our locations, and my boss, the CEO of Catholic Health, Mark Sullivan, said, I need you to do something. I need you to lead the incident command effort for Catholic Health. I had run incident commands at the hospital before. We've dealt with power outages. We have dealt with downtime as far as our electronic medical record. We've had water outages, water main breaks, security issues even, but nothing quite like what we really were expecting or what we thought could be a major concern to the Western New York community and certainly our health system as a whole, and really just all the health systems. So as Mark, my boss, tapped me to take a look at that, the first thing that we started to do was really develop an incident command structure. And we do have a team of folks that were getting data from, at the time, if you remember, some of the first areas within the country to surge for Washington State. Take a look at all the information that we had at our fingertips that spoke to COVID, spoke to what we did know about the disease, how is it transmitted, what was the shedding period, what were some of the things that we could expect as we started to see patients present. We kept our board in the loop, which was important because from a resource allocation perspective, we really needed to make sure that we had everything at our fingertips, and communication and timing was really of the essence. And then what we did is, it seems kind of funny, but we ultimately had the equivalent of like a draft, an NFL draft as we have here on the slide. We took a look at the different areas, and I'll show a slide later that speaks to how I set up the incident command structure. But what were the areas that we needed to stratify our leadership team to really get after, what we thought was really gonna hit us and hit us soon. The one thing that I think stuck out to us, and the one thing that I think we knew more than anything that we needed to be sure of, is that we wanted to try to create a model that really centralized our care around the patient, but really when we looked at the resource allocation perspective, beds and PPE burn rates and testing functionality, we wanted to really look at the possibility of a single location. And for us at the time, we looked at one of our acute care facilities, and St. Joe's was under my periphery at when I was at Sisters, but also as the acute leader. We had a low census at the time, and we looked at it as how could we set up this building to really be our COVID center. And that really became like the catalyst for all the work that we built around the rest of the infrastructure and system that we created as far as our incident command mobilized and then ultimately became. We made a decision, and I think that's one of the first things. This was mid-March, was St. Patrick's Day weekend. You know, everybody probably saw the news stories of folks still having cocktails on rooftops and everything in between. We were looking at this, and we started to see mounting PUIs into our emergency departments. So we mobilized relatively quick, and we made a decision on March 20th that we were going to close the emergency department at St. Joe's, empty the building, discharge the patients, transfer the patients, clean the building, and begin the setup of transforming St. Joe's into a COVID treatment center. The ED was officially closed on 3/21 with New York State, and we saw our first patient there on 3/26. And in that 5 days, we did everything from construct zones. So we had a red, a yellow, and a green zone. The red zone is full PPE. We basically had a yellow zone where no employee was able to touch anything within it. It had to be masked and gloved to walk through it. And then we had a green zone, which was where our break room and some of the training and other aspects were set up. This was mobilized quickly because we wanted to try to get patients over to St. Joe's as quickly as possible. So when you look at the goal, and you see the shield here that comes up, the first thing that we wanted to try to do in making this decision was protect the integrity of the other buildings. We really wanted to protect all of the other patients and staff from, a highly contagious disease. And in doing so, how could we do that in the best possible manner? That was why we made the decision to establish the treatment center here to the left. As we started to get patients that flooded the emergency departments, we were able to utilize our partners at Strong Memorial initially, and then a platform out of California with the help directly of Governor Cuomo's office called Cepheid that helped us perform a rapid test in our emergency departments. So as patients presented to the emergency department with symptoms, they didn't leave the ED. They ultimately were tested, swab tested, and the turnaround time for this rapid platform was about 45 minutes. We were able then, within an hour, hour and a half, to determine whether a patient was positive or negative. And if a patient needed to be admitted, that patient was then transported to the St. Joseph Campus Treatment Center, where they were cared for really in COVID dedicated units on the medical surgical side, as well as the intensive care. When you looked at the kind of the challenges that we saw, and a lot of folks probably heard or read about this across the state and the country, was really, it became an issue of resource allocation. You see at the top, beds, so the number of beds that we had available to cohort patients that were all highly contagious. The ability to actually utilize equipment, especially ventilators, because early on, as we didn't know much about this disease state, we saw a very high percentage of patients crash from medical surgical to intensive care and require ventilator management for extended periods of time and almost immediately upon presentation to our facilities. PPE, we were trying to secure everything from N95 masks to isolation gowns to gloves to regular surgical masks. And as you can imagine, they became at a premium across the country and world, at which point we were paying anywhere from $7, $8 to a mask. And that really threw us through a tremendous hurdle and loop, not just securing PPE, but stockpiling it and figuring out a way that we could put all of this equipment and protective equipment for PPE in a centralized location to be able to really manage this patient population, this influx that was coming into St. Joe's. One of the other things that really isn't talked about much, aside from the St. Joe's Treatment Center from an acute care, we also have the community-based St. Joe's Post-Acute. We had patients that were discharged but still shedding the virus for up to 14 to 21 days. So what happened there is we couldn't send these patients home. We couldn't send these patients back to the nursing home. So we actually converted an old nursing home in Orchard Park to basically a COVID post-acute center that allowed patients that weren't well enough to go home or were still contagious and had to go back, you couldn't go back to the nursing home. We were able to place them in this like basically COVID only nursing home until they were clear, until they were no longer contagious and had a negative COVID test. The important thing that we wanted to make sure of is that we had consistent care across our continuum. And one of the things that was incredibly important as we went through this process was really the cohorting of staff. The local unions were extremely supportive. We were able to really establish quick MOUs, memos of understanding, that really superseded our existing collective bargaining agreement, which allowed us to then flex staff across all of our facilities. The challenge is that when we saw a significant number of patients that were extremely ill in the ICU, we did not have enough critical care nurses. So what we did is, in our partnerships with the CWA, and certainly with our educators within our system, our clinical education, we created ad hoc education in the lobby of St. Joe's, where we set up our lobby to really help the staff learn and experience what they were going to see up in the intensive care units. And this was ad hoc training that took place very quickly, right on site, as staff was going up to work their shift, for the St. Joe's COVID Treatment Center. We mobilized telehealth as a platform, and we have a robust home care program that we ultimately utilized as well to really keep folks out of the hospital where and whenever possible. So as we kind of worked through the model, one of the things that was important for us, and what I have here, was really the how we moved our patients. This picture that you see here is our incident command, our transfer center. What you see in the middle is the bedboard, and what you see across the top and on the sides are the emergency departments across our system. This was really ground zero. We had a patient that converted from green to red. We knew that patient had to be transferred to St. Joe's, and we had an incident command staffing team that then coordinated transport with the ambulance company to move those patients over to the St. Joseph campus. This is the lobby, the picture of St. Joe's. This is what you see here. These were the modules that were set up. You have an ICU bed, you have a ventilator, you have a CRRT, which is continuous renal monitoring, over on the back half of the picture. These were things that a lot of our nurses weren't used to dealing with, and certainly weren't used to dealing with as it pertains to COVID. And so we had this training set up in the lobby. We pushed over 1,000 people through to just learn through these different modules in the first week that St. Joe's was open. What I have here is a picture of my incident command structure. Every morning we met twice a day. Every day we met twice, once in the morning, once at end of day, and we stratified the different areas of just where we thought we needed focus: infection control, our clinical team, our transport, emergency management, the supply chain, which focused on PPE, public relations, which was a communication piece that we had to make sure of, anything legal from a compliance perspective that we had to work through the state, and then ultimately we reviewed the dashboard. How many patients did we have? What did our staffing look like? And then what was our expected day going to look like, depending on how busy the EDs were at the moment. This is a dashboard that we used. What this gave us was the number of beds that we had currently available to us, how many COVID cases, how much surge capacity we had, and unfortunately how many patients we had in our morgue at any given point in time, which also presented at times a logistical issue with the local funeral homes and their ability to come in and take seizure of the bodies. This was reviewed every single morning, and this was something that we kept front and center as we mobilized or looked to navigate through the pandemic. And then just quickly, before we get into a Q&A and a wrap up here from the formal presentation, how did it work? We saw over 620 transfers that were moved from the other Catholic Health facilities over to the St. Joseph campus. We had more than, get through this here, 1,500 patients that were treated at St. Joe's, and to date we've discharged over 800 from that building. We had zero COVID, and to this date have zero COVID at any of our other facilities. And we were able to maintain the integrity of keeping those buildings clean to the point that when we saw the COVID peak subside a little bit, we were the first health system in the state, one of the first in the state, that Governor Cuomo allowed us to resume elective surgery, and that was on May 5th of this year. That's important because from a financial perspective and from a pent-up patient need perspective, we had all of our elective surgeries, all of our clinics, all of our offsite locations were shut down beginning in mid-March. So our ability to keep our other buildings clean allowed us to basically restart our elective work at all of the buildings outside of the St. Joe's Treatment Center. This really just shows our trend, our dashboard, some of the things that we looked at as far as percent positive, daily arrival departure, and you can see really where we peaked and where we've been since then, which is a significant, we are very stable right now from a community and certainly from a health system perspective on COVID. Christy, that's all I had as far as the formal presentation. I know I went quick, but I wanted to leave enough time for an open dialogue and a panel discussion.
Excellent. Thank you so much, Marty. I know I was able to see this on the news in real time for so many weeks and months, but to hear you and to see this firsthand, I can just say, wow, it's amazing everything that you all have done. I guess we're all probably proud to be a faculty, staff, alumni with one of our very own leading the way. So thank you so much for sharing this great information. We have some great questions that are coming in. I want to start, I know you just talked about meeting, first thing in the morning and later before the day was concluding. This person that submitted the question is asking, how did you engage middle managers in your planning?
Yeah, that's a good question. So the system incident command is really like a trickle down. So we have a system incident command, and then we had an incident command for the COVID only hospital. And then each of the local sites had their own incident command structure that really mirrored the system incident command. And so part of each incident command structure is communication PR. When we say communication PR, it's just not external communication. It's more important internal communication. So each of the sites had their takeaways for the day. They were part of the evening incident command. Everybody reported out on what was working, what wasn't working. And then each day at the conclusion of, we took all of the important information and we posted a COVID daily update to our internal website. That information was then circulated to all internal resources, not just management, middle management, but everything in between. So it was really a multi-pronged approach of communication. Some of the folks participated in the structure itself. Others were notified via whatever mechanism we use. In this case, it was almost like a minutes document each day.
Fantastic. Marty, the next question here, you talked in the very beginning about testing. Was the lack of testing ability early on for Catholic Health Collided due to the lack of resources or lack of knowledge about the disease so early in the pandemic?
I think it was a little bit of both, and I don't know if it was chicken or egg, but I think across the country, we did not have an adequate testing strategy or the ability to test. I think where we are today is much better than where we were in March. We now have 5 different testing platforms. So we are still using the rapid sepia test, which was the first that we were able to secure. And then we have 3 or 4 other platforms that range anywhere from 5 hours to like 12 hours as far as turnaround time. So I think from a resource perspective, our labs were quite equipped to be able to handle the demand of testing. It was just the reagent, which is the ultimately what you mix the swab with to determine if you yield a positive or negative test. We did not have access to that, nor did a lot of places throughout the country. So our ability to do contact tracing and to really isolate was hindered because by the time we were able to deploy a testing strategy, we had a significant number of hospitalized patients.
Excellent. Marty, the next question we have here, the facility was open for COVID from March 19th to August 3rd. Are you and your team ready to reopen Pivot if another surge happens? And then part B of that question, how fast could it happen since you know from the first time?
So the part B is the $1 million question, but yeah, so the part A of that question is that we still are meeting 3 times a week with Incident Command. Not quite the frequency that we did early on, certainly during the peak of. We follow the same structure that we did in March, April, May. And so we are ready. I think it's going to be a little bit more of a hybrid approach this time. I think we had lightning in a bottle the first time with St. Joe's in the sense that, we made the decision, we mobilized, we were able to concentrate staff and resources to St. Joe's. And part of the reason we were able to do that was because we ceased all elective work. We closed our clinic. So we had a bandwidth of staff that was actually able to be redeployed to focus on the COVID center. Now, that could certainly happen again. But if you have this like slow ebb and flow that we've seen, we've seen some weeks, days where we've seen a little bit of a spike, but then it seems to go back down. I think if we maintain any level of elective surgery, right now the emergency department is opened at St. Joe's. It'll be a hybrid approach where we're still going to utilize St. Joe's as the predominant relief valve, but we also have a plan to treat in place at our other locations in the event that we see a significant spike. And then as far as, if we see another spike, do we think that we will? I think the fact that we do have a more robust testing strategy right now across the country, certainly in Western New York, we are testing every single patient that presents as far as elective surgery. Before surgery, they get a test. Anybody that's symptomatic, even if they don't require admission to the hospital, is getting tested. Primary cares, third-party lab stations, everybody's doing significantly more testing. So I hope that will provide a positive impact. And I do think that, for good or for bad, all the political stuff aside, I do think wearing masks does matter. It certainly matters in the healthcare environment. We have seen a significant decrease in our number of our associates that have gotten sick, and certainly the masking we do believe helps.
Excellent, thank you. Marty, the next question here, we've all heard that term new normal. So we talked about, if there's a surge, how you would reopen, but how do you plan on returning to the new normal of non-COVID functioning? And how do you deal with a reentry to healthcare operations?
It's going to be challenging, and I think that we're gonna see the remnants and the impact of this pandemic for a long time. I don't know when things will get back to normal. It depends on what you see, read, believe. I think we're going to see, some component of COVID in our life, certainly through the majority of 2021, unfortunately. I know that we're hearing, hoping that a vaccination is on the horizon. And if that is the case, that's great. But I also believe that the ability to mass produce, risk stratify, administer the vaccine is going to create a whole different logistical issue across certainly New York State, Western New York, and the country. As far as the new normal, I mean, we're back to functioning as a healthcare system. Most of our elective procedures are back and have been since I mentioned mid-May. We have seen a significant decrease in our emergency room traffic, and I think there are people that are still reluctant to come out, even the folks that are sick, and certainly the folks that were using emergency departments as primary care. We have seen a dramatic reduction in the lower acuity ED volume, emergency department volume. So the new normal for healthcare is going to be, I think we have an uphill battle in front of us. I think the cost and the damage that this has done to our healthcare system is going to be longstanding. I think all the healthcare systems are going to have to take a look at doing things a little bit differently in the future. I think it's taught us to be nimble. I think we're going to have to leverage technology. Telemedicine is a platform that I think you're going to see take off as a result. But I think the healthcare systems that'll survive, advance, and do a great job in the future will be the ones that are really innovative, and take this as something that they learn from, and how do you make things better as a result on the backs of something that's so terrible.
Absolutely. Marty, when it comes to lessons learned, this next question that's been submitted states, is there anything that you would change if there was another surge?
It's hard. Things were so fast and furious. I mean, certainly there was a million things each day that when you go back, you're like, I would have maybe done that a little bit differently. I think one of the things that I think were important for us to look at is, I think we need to, you take the drilling and the tabletops and emergency management, and you look at it and you say, okay, how often is something like this really going to happen? I think our ability to be ready and to mobilize, I think it's just so important to make sure that you're really having a regular touch point with your staff, as far as all different sorts of emergency management. And it may be situational, it may not be, but at the end of the day, I think how you set up your structure, you need to be prepared to pivot and move quickly. And I think in some cases that's very difficult in an organization that's fairly large. So for me, I think it's more a matter of taking what we learned and staying ready in a go forward approach versus reacting, which is what I think a lot of us were doing initially and early on.
Sure, definitely. Marty, this next question, we all know you mentioned one of the first COVID centers. Did colleagues across the country reach out to you for advice on best practices as they set up their own centers? And if so, what were some of the highlights of information that you did share with them?
Yeah, actually, we just had a call with some of the heads of Health and Human Services a few weeks ago. We did a WebEx, a Zoom meeting with a few members of the incident command team. We talked about the decision point around St. Joe's. We talked about the zoning. We talked about the training, the real-time training that took place in the lobby. We talked a little bit about the Post-Acute Center. Those were some of the things that I think we took away as best practices. And really, I think the biggest thing for us was just making a decision. I think indecision in times of crises are really the worst decision. And, for the few days leading up to the decision point around St. Joe's, and I have to give my boss a lot of credit for this, is I was trying to make sure everything was perfect. We were trying to, try to figure out, okay, if we do this at St. Joe's, if we put up this barrier, if we put up this wall, if we set up PPE here, if we have this amount of traffic, use this elevator, we do these types of things at the treatment center. And you're never going to be perfect. And it just came to a point where my boss basically said, we're announcing this, we're doing this, be ready. And so, the little things that fall into place are important, but I think ultimately making the decision of directionally where you want to head is probably one of the most important lessons I think that I learned and that we learned through this. And to really just sit down and make sure that you have time to yourself to really map out what your strategy is, because you're going to have a million people in your ear telling you, did you think about this, this, and this? I think you really just need to make sure you're staying laser focused on what you want your outcome to be. And for us, we had a couple things, and that was really protecting the integrity of our other buildings, concentrating our resources, centralizing our staff, and making sure the staff that we were centralizing was protected. And the only way that you could do that would be to cohort your resources in a singular focused area, which was what ultimately became St. Joe's.
Definitely. Marty, I have two questions that are kind of quite similar, so I'm going to give them to you both at the same time. So the first question, I'll say part A, how do you work to prevent employee burnout from a COVID dedicated hospital? Must have been difficult for those working at St. Joe's to distress from the tough cases they were coming across. And the similar question, part B, have you seen PTSD with any staff?
Yes, unfortunately, both. I think some of the psychological impact that some of our staff witnessed, you have to remember St. Joe's pre-COVID had an ICU census of 2 patients, maybe 3. It's a small community hospital, focuses on really surgery, orthopedics, GI, a handful of other things. At the peak of the pandemic, we had over 115 patients there, of which 60 plus were in intensive care, and most of those were on ventilators. So these were things that most of the staff hadn't seen, and some of the ventilators were long-term. I mean, we had patients that were on vents 40, 50, 60 days. And then we unfortunately saw a significant amount of death, more than most of those staff, the folks that were caring for those patients, had seen probably in their careers. Most of the patients did okay, but we still saw over 100 deaths at St. Joe's in a 2 to 3 month window. So that took its toll on the staff. And some of the things that we did is we converted our metabolic center, which is really like a huge gym, into a break room, a lounge for the staff. We had spiritual care. We had availability of counseling. We fed the staff every day. So we wanted to make sure that they didn't have to worry about things like meals and other things. And simple things like just the ability to change their clothes. We provided scrubs so they didn't have to work, even with full PPE on, that they didn't have to come and leave in the same clothes with the fear of bringing that home for their family members. But still, to this day, we still have folks that have challenges, and it was a really dramatic time for any of the folks that worked through that. We had staff that did get sick, albeit few and far between. But that took its toll on people mentally, and it was a really tough environment to come out of. So we're making these resources. It's called Listening Hearts. It's a program that we contracted with for outside counselors, third party, anybody that needs it to actually seek some additional help. And then we encourage, talk to each other, some of the folks that have been through it with you in the battlefield, to go through this and really, work through it, talk through it, however you're comfortable with. And then we've been very sensitive to some of the demands that have been put on those people. And it was just, I can't underscore it enough. It was really, really, really tough situation.
Oh, I can only imagine. And we certainly have some healthcare heroes out there. So a big thank you to them all. While we're on the questions of staffing, this next question submitted, did you assign staff to work at the COVID center, or did doctors and nurses volunteer to be moved, or did current St. Joe staff adjust to new roles?
It was actually a hybrid. There wasn't a lot of assignments like mandation. I think there were a couple shifts throughout the period where we got to that point where we were working with the unions to make sure that we could staff the building as a whole. But I can't, it was incredible the amount of people that ran into the fire, that volunteered. The first week when we announced St. Joe's, we did it exclusively by volunteer. And I think we had like 1,100 volunteers the first week, from all walks of employment, from environmental services to respiratory therapy to certainly nursing and nursing assistants. And we built our staffing grids and structure based on that first and foremost. But there were times when the census got high and the weekend shifts and people were working tremendous hours, where we still had holes and pockets of challenges, where we would do our best to call, solicit, and 95% of the time that was effective and worked. But there were a handful of times where we did do assignments in cooperation with the CWA, but few and far between. I think the most impressive thing, it doesn't surprise me with the nursing staff, with all the healthcare workers that I've seen in the 10, 11 years that I've been here, that more people ran into the fire than you could possibly imagine. I mean, it was just incredible how people just did their thing, put on their PPE, and took care of the patients. It really was a pretty remarkable thing.
Yes, definitely. This next question here submitted, Marty, how did you deal with all the staff testing and testing of affiliated students, especially during the early on times?
Yeah, I mean, so the testing really became a function of when someone presented and was symptomatic. Early on, we didn't have any testing algorithm outside of the rapid test that was for only symptomatic patients that were going to be admitted. Over the subsequent 2, 3, 4 months, there was an antibody test that was developed that we utilized, and then we rolled out pretty robustly across for staff, especially if we had any staff get sick. We then expanded it out to where contact tracing, where that person may have worked. But just like anyone else, it started off with very limited testing capability. So it really became a function of if you didn't feel well, you went through your screening for the day, there was a temp scan, a symptom check, that you really were asked to stay home. If you didn't get better, you still felt ill, then ultimately it was like anybody else. You sought care, through your primary care or certainly, the hospital. But testing was absolutely at a premium early on. Now I'm proud to say that, if anybody, requires a test, we have the ability to certainly do it. But yeah, early on, it was definitely a challenge.
Sure, definitely. All right. The next question, Marty. If the next wave of COVID is significantly worse than the first wave, what is Western New York's and Catholic Health's capacity to address maybe a new wave surge in the future?
I think it's similar to what we did last time, what we did and what New York State, where we work in collaboration. We work very closely with Governor Cuomo's office directly through the pandemic and certainly setting up St. Joe's. We identify surge plans and surge beds. So we look at areas like, ambulatory surgery. So the spot in the hospital where you go before and after surgery, PACU, the spot where you go recover after surgery. The emergency department. We flipped the emergency department at St. Joe's into an ICU. So at one point we had 5 different ICUs open at St. Joe's. So like that's some of the work that we do. You do your physical bed count, how many actual beds do you have, and then you look at stretchers, and then you look at locations for those, and then ultimately you look at how you can staff it, where you can staff it, and whether you concentrate the care, you treat in place, or you do a combination of the two, which is the direction that we're going to head. So it's certainly the ability to be nimble. I think you have to do that. But as far as surge plans goes, we've identified each of our locations, the number of beds that we could surge up to in the event that we saw a significant spike.
Excellent. All right, Marty, the next question here. Did you accept COVID patients as transfers from the Kaleida system, so more like a Western New York COVID dedicated hospital versus a Catholic Health system dedicated hospital?
No, initially it was just an intra-system mechanism. We had looked at the possibility of it, but between testing and what was happening in our own emergency departments, and from a staffing perspective, we capped out pretty quickly as far as what we could take and accept. I think I mentioned during the peak of the first wave, we got up to about 115, 120 patients, and we had the ability to flex up to maybe 70 ICU and 100 med surge. And as the EDs became inundated, we were transferring more than we could ultimately catch during a wave of time, a period. So really the focus for us was really it was on the Catholic Health patients to start. We were certainly open to looking at it in the future, and I think a community standard is something that I think needs to be discussed if we go through this type of issue again. But it wasn't a deliberate attempt to box out Kaleida in any stretch, or ECMC for that matter. It was just a matter of the timing and how things really kind of shook out, and how busy our EDs came and how quickly it happened. We went from patient 0, patient 1 to patient 70 in less than 3 or 4 days. So it happened really quick.
Absolutely. And Marty, this next question, you mentioned, incident commands such as water main breaks, electrical outages, all very short term compared to the pandemic, which at this point, we don't have really an end in sight. We're hopeful for something soon. But how did that affect the planning with the incident command team, that long-term crisis planning versus short-term crisis planning?
Yeah, it was just an open-ended thing. And I think we used the structure each morning and evening to see how things were going, what the outlook looked like, how many patients we could accept transfer in for on any given day or point in time, what we were looking at as far as discharges, capacity, continuing to secure staffing. It was just one of those things you just did. So we had incident command effectively open 7 days a week. Folks, I spent a lot of my time at Genesee Street, which is where our corporate headquarters is. That's where we had our system incident command. Between here and St. Joe's, I spent a great deal of time. I mean, folks were able to go home and certainly, do what they needed to do, but the amount of hours that were put in by the incident command, the folks that had formalized incident command roles. I mean, you were talking 14, 16-hour days, 7 days a week for the better part of 3 months. So I think the stress that it put on the incident command teams across the organization were tremendous. That's since subsided once we started to see a decrease, and certainly as we are today, you know, there's not a tremendous amount of COVID at Catholic Health or really across the community right now that's hospitalized.
Well, that's very good to hear right now too. Marty, the next question, we talked a lot about, you know, staffing, and now I want to shift to the financial side. This question says, have you survived with reimbursement for the care that you delivered?
So it's funny, there's a lot of misnomers out there about the premium, the add-on. If you designate a patient as COVID, you get a higher reimbursement. You know, reimbursement works. There's actually like it's called DRG in healthcare. So every patient gets assigned a DRG, and your payment is based on acuity. And so you do have really sick patients through that. But as far as the financial reimbursement versus the cost, no, the ends did not meet. The health system has tremendous financial pressures on it right now related to COVID. We did receive CARES Act dollars. We received a significant amount of CARES Act dollars, the 70+ million, but we're still projected to lose, you know, significantly more than that. That'll be a drop in the bucket compared to what we're looking at for year end. And in addition, we've seen volumes that haven't come back, which present a whole different challenge. I think I mentioned early on, our emergency department is not back to pre-COVID levels. Some of the elective work, people are still leery to come back into a hospital, even though they might require an elective procedure. They might be putting off a knee replacement, a hip replacement, you know, some type of repair that they could otherwise, you know, they would have otherwise done, but they're living with. So we're still dealing with some of the aftermath as it pertains to that. But the reimbursement as a whole, I think most health systems in the country that saw a significant amount of COVID will tell you that it did not support the cost of incremental labor, hazard pay, PPE premium, testing, new positions that were created. We created positions out of thin air. We have screeners now that are, you know, screening different areas of our buildings. We have donners and doffers, which actually help people put on and take off their PPE. We have patient escorts that are walking patients through the buildings, you know, from a surgery perspective, because we still have limited visitation. So we have a significant hurdle in front of us, certainly until we get to the other side of this from a financial perspective.
Marty, I continue to be amazed as I learned so much today. I also want to go ahead and ask you about this next question. You mentioned some staggering numbers that you, patients that you moved out, you know, from St. Joe's, and COVID patients that you moved in. How complex was that, you know, from a logistical standpoint?
So you saw the picture of our transfer center. So what happens is that in that transfer center, you have all of the live, it's the live feed of our emergency departments. So you flag a patient that has COVID symptoms. That patient is then tested. That patient was then put in the queue in the transfer center dashboard. And then you had, you waited for the test result. Assuming the patient was sick and positive, we then initiated the transport with AMR, who is the ambulance company. And then we had accepting physicians at St. Joe's that were readily available. So then we got the team ready. We had a team that transferred with the patient and then received the patient to St. Joe's. So it was a direct admit. The ED at St. Joe's was closed, which is one of the decisions that we made to decrease the complexity. So we controlled the traffic of patients into the building. So what we tried to figure out is how you could minimize the number of variables that would actually complicate things. And if you have an ED opened, an emergency department opened, that would have been tough to do, because you have to make sure that you can navigate between the patients that are in your house, that some might be COVID, non-COVID, versus controlling the entire intake process, which is what we did by shutting down the emergency department at St. Joe's. Any patient that entered that building, we knew was COVID positive. We already had orchestrated the sending physician, the receiving physician. They had already had a handoff, which means they talked about the status of the patient. So we knew whether the patient was going to immediately go to the intensive care unit or a medical surgical unit. And the nursing staff with the, the respiratory therapist and the team brought the patient to the wherever they were going once they hit the door. So it was complex to work through the logistics, but once we got it, the process worked quite well. Every morning at 7 a.m., we had the medical leadership in the system talk through the number of transfers that they had ready to go. And they basically were the ones that gave the green light from a clinical perspective to orchestrate the transfer and the physical movement of the patient.
Wow. All right, Marty. I have one final question for you here, but I do want to thank you. There's a first responder on the line with us who just wants to thank you and your Catholic Health team. She said she wouldn't want to be in another community than right here in Western New York. So a big shout out to you all and thank you from one of our attendees here. Just to kind of wrap things up and kind of conclude today's presentation, what would you say, this next question, what are the biggest lessons learned from this experience overall?
Yeah, I mentioned it before. I think, indecision is a bad decision. I think you really have to, in the midst of the stress that everybody was dealing with, what I learned is to just remove myself a little bit, have some time to actually think through what we wanted to do, and then stay the course, because you're always going to have nuances. You're always going to have reasons you shouldn't do something, or risks in making decisions. I don't think anybody really knew what to expect. So I think you really have to be laser focused on what you want your outcome to be and then work towards it. I don't want anybody to interpret it the wrong way, that we didn't make mistakes or that there weren't things that we could have done different or better. I just think that, if we didn't make the decision to convert St. Joe's early on, stop elective surgery, close the emergency department, I think it would have created a whole different series of events and issues that we would have been dealing with in across our system. And then the other, I think, important thing that I think matters is pay attention to the little things. One of the evenings when we were trying to figure out how we could get test results quicker, I received a phone call and I wasn't going to answer it. And it was from a pathologist at Strong Memorial, who basically offered to take 100 samples whenever we could get them to him, and turn them around in less than 24 hours. That allowed us to basically empty our buildings at the time of patients under investigation, because now we were able to yield positive results or negative results and really get back to protecting the integrity of the building. And this is before we had the rapid testing platform. This is the first week of St. Joe's being open. And it's like, so you think about all the details, and there's certain things that you got to trust other people with, but just be cognizant of your peripheral vision and making sure that you're listening, because you never know when someone might be offering you a hand to help.
Fantastic. I couldn't agree more, Marty. Thank you so much. You have more thank you messages coming in, so I know I'm going to speak on behalf of a few people here. Thank you so very much for your time today on behalf of the Office of Alumni Engagement, the UB School of Management. Thank you for all the work that you continue to do in Western New York, and I know you are sharing your best practices broadly as well. So thank you for sharing your knowledge and expertise with us today. As a reminder, we've recorded this conversation in session with Marty. We'll send you all the link within the next 24 hours if you'd like to listen back through and hear more of the points that Marty touched on. In addition, save the date for next week. We have our Webinar Wednesday series, and we'll be welcoming back UB School of Management Professor Jim Lemoyne. Jim is going to speak on how to discuss your differences with others, understanding and talking to people who don't morally or politically agree with you. More information on all of our upcoming webinars, as well as our webinar archive library, can be found on our website. But with that said, I'm going to turn it back over to Marty for any closing remarks.
No, I just want to thank everybody for taking the time, listening to our story a little bit. I think we have a good one to tell. I'm not sure that it's over yet, but I think for me, and as I reflect and I was preparing for today, I think the most important thing isn't really what the incident command or what Catholic Health collectively did. It's really what the front line did. I mean, you hear the word the healthcare heroes and the frontline staff, and I'll just say it really is nothing short of remarkable. So as you reflect on the instances of, there's certainly lessons learned from a leadership, from a navigation, from a logistics, but I don't think any of that's really not possible without good people. So for everybody in their organization, some healthcare, some not, I think the recognition of what everybody has done for the last 6 months on the front line is more important than anything that myself or any of my counterparts on incident command or leadership could have done. And I'll just close with that, Christy. But thank you. I appreciate everybody listening.
Fantastic. Thank you so much, Marty. Thank you. I know we have frontline workers on with us today, so a big thank you to everyone. Take care, stay well, enjoy the rest of your day, and thanks for leading the way here in Western New York, Marty. We appreciate it. Thank you.
Thank you.
Bye-bye.